at the outset like to thank AIOS and Scientific Committee, Dr. Partha Biswas and the entire organizing team for hosting this wonderful conference. So without wasting much time, I think we'll go ahead with the topic. The first topic will be from Dr. M.S. Ravindra, and due to some emergencies, he is not able to attend it, but he has sent the video recording. So this IC basically is on lost bag, not a lost battle. So sometimes we fear that what if the bag goes wrong, if there is a decentered IOL, if there is a dislocated IOL, if there is a dangling IOL, and many other circumstances which we face across in day-to-day operations or day-to-day surgical complications. So that's what we need to face that and how we can solve these problems. So we have a host of luminaries in this program, in this IC instruction course. We have Dr. Suhas Haldipurkar sir, we have Dr. Deepak Megur, Dr. Gaurav Luthra, Dr. Vishal Agarwal, Dr. Aditya Kelkar, and myself will be covering this topic. So without wasting much time, we'll move ahead with the first talk by Dr. M.S. Ravindra, and I thank Dr. Partha Biswas sir for giving this wonderful opportunity. So we'll go ahead with the first presentation. I request Vishal to please come up on the dais. And the sound. Can we play the presentation?
A lost bag, even today. Since below.
Okay, it's coming. Okay. So the first presenter is by the video presentation by Dr. M.S. Ravindra.
Faculty and to the delegates, AIOLs will salvage a lost bag, even today. Since Baron of France introduced AIOL for the first time in 1952, there are many designs which were introduced, and the most successful of them is Kelman quadriflex IOL. There are contraindications with poor damage. Endothelium, iridocorneal angles are not good. Iris support is not there. Chamber is shallow. Pediatric age group, we would certainly avoid AIOLs. A constant is 2 to 3 diopters less than posterior chamber lens. Sizing is most important factor in minimizing the complications. It needs to be 1 millimeter larger than the horizontal white-to-white diameter. The sclerocorneal tunnel is 6 millimeters because these are PMMA IOLs. Iris root should not be incarcerated by the haptic loops, and haptics should rest against scleral spur anterior to the iris periphery. 1% pilocarpine to construct the pupil before insertion helps you to avoid peak pupil. Vitrectomy and peripheral iridectomy are part and parcel of implantation of an AIOL because of a compromised the capsular bag or zonules. Most of the problems that we see is because of implanting the lens concave anterior. The lens has to be implanted convex anterior. If you look at the profile of the lens, as you can see here, there is a vaulting anteriorly of the optics. The haptic has to be behind so that it matches with the configuration of the anterior chamber. Complications are known: increased and prolonged inflammation, glaucoma, UGH syndrome, upside down syndrome when you implanted the lens upside down. We have a stock of all the lenses of AIOL. Though it is rarely used, I would rather prefer an iris clip lens. But these are definitely something which is of value when you have a complicated situation. Is it accepted in the literature? Yes, as late as 2003 to 2007, there are a couple of articles. One is a meta-analysis published by the American Academy, where all the 3 kinds of secondary IOLs are equivalent as far as results are concerned. By Michael Wegener, Donaldson reported that there is no significant differences in the outcome of visual acuity and postoperative complications. And a couple of studies even said that the results of AIOL is superior to any other kind of lens. So that is the status where we have done a vitrectomy. We have lost the capsule and the lens is very carefully guided within the viscoelastic so that the leading haptics go and impinge upon the anterior angle, distal angle. And there are 2 ways of implanting it: to either hold the haptic and then push it, or it can be very gently inserted using a T-dialer. T-dialer pushes it and each of the trailing haptic is inserted into the angle region. A tunnel of 6 millimeter is essential, and after that I would like to implant the lens horizontally all the time, so that because of squeezing action, when the lid is pressing, upper lid is pressing on the globe, it can cause tenderness for a couple of weeks' time. If it is implanted vertically, the long axis is vertical, so I would always like to rotate it. I would have liked the pupil to be a little smaller than what you see here, but then this is the way I withdraw it from the angle region and very slowly position it alternatingly each haptic so that it doesn't rub against the angle region. Deepen the chamber to a certain extent so that the periphery of the AC falls back from the cornea. As you are withdrawing the haptic away from the angle region, slightly lift it up so that there is no impinging of periphery root of the iris against the haptic. So withdraw it from the angle, lift it up and release it. That's what I do. Continue doing vitrectomy. Ensure that the viscoelastic is completely removed from the eye so that post-operative pressure hike does not occur. Patient would certainly need anti-inflammatory drops for a longer time after the surgery. And there's another case where soon after a couple of weeks' time you notice the lens is not stable in the eye. Patient already had undergone vitrectomy during the primary procedure, and the lens is not well supported by the capsular in the sulcus area. It's decentered, so it's a sclerocorneal tunnel, a short scleral tunnel. It's very difficult to open the sclera even at few weeks after the surgery. Lignocaine into the anterior chamber, 1%, to anesthetize is done under topical otherwise. The lens is rotated into the anterior chamber under the protection of viscoelastic. This is a PC lens. Bring it to the anterior chamber. There is no vitreous in the vicinity because of the vitrectomy done during the primary surgery. Repeated injection of visco is very important. Take your own time and pull both the haptics out of the posterior chamber into the anterior chamber, and then bring it in line with the tunnel, and then explant it by holding with the lens holding forceps. A Kelman forceps is of no use here. It has to be a lens holding forceps, as you can see here. Hold it up and then pull it out of the eye. This lens, as I said, the convexity of the haptic optic should be anterior so that the haptics don't press on the angle region. The trailing haptic is positioned in the angle region now, and viscoelastic in the anterior chamber is repeatedly infused. Visco is aspirated completely. If necessary, vitrectomy could be done even here when there is, in case vitreous presence. Sizing is important. As you can see, the pupil should be round and it should not be peaked towards the haptics. By carefully planning the surgery, we can avoid endothelial damage, prolonged inflammation, UGH syndrome, and secondary glaucoma in such cases. In certain special situations, ACIOL can certainly be an alternative to the iris clip or scleral fixation lenses. Thank you.
Thank you, sir. Though Dr. M.S. Ravindra, sir, was not able to come because of some family
in this video,
emergencies. So I would like to thank him very much for presenting this video. So next we have Dr. Deepak Megur, and after that we have luminaries sitting here, Dr. Suhas Haldipurkar, sir, and Dr. Aditya Kelkar and Dr. Vishal Agarwal. So I'll be next taking Dr. Deepak Megur's talk. So he'll be explaining the IOL trap technique.
In this video, I'll be sharing a few of my tips for performing a phacoemulsification in eyes with zonular weakness, and also I'll be describing about this IOL trap technique. So let's find out. Eyes with generalized zonular weakness secondary to pseudoexfoliation have been a challenge for us cataract surgeons, because apart from the intraoperative difficulties which we face, long-term stabilization of these lenses is also a concern. So over a period of time, we do see late onset spontaneous spontaneous dislocation of these lens bag complex in quite a few number of cases. To counter this issue, the technique of IOL trap can be utilized. Let's see how the principle of IOL trap technique works. The CTR is put in the bag, which provides equatorial support and stretch to the capsular bag, and then a multi-piece hydrophobic lens is placed such that the haptics are in the sulcus while the optic is pushed back behind the rhexis to achieve an optic capture. This technique seems to provide better long-term stability in a select group of patients. Of course, we are all aware that for more severe zonular weakness, CTR along with CTS, which anchors the bag to the sclera, is probably the most accepted and preferred standard technique. So let me share a few of my experiences with the IOL trap technique. I have been using this technique for the last 5 years. To begin with, phacoemulsification itself is quite challenging in such eyes with weak zonules. Now, how do we anticipate significant zonular weakness? Apart from the mild phacogenesis which we can pick up from the slit lamp, certain intraoperative signs give us enough clues. Number one would be increased space between the iris and the lens. This is indicative of the fact that we may be dealing with loose zonules. Number two would be when you try to puncture the anticapsule for rhexis, it is difficult to pierce it, and we see these wrinkles in the anticapsule indicating generalized laxity of the zonules, and tearing of these capsules is also difficult because of the lack of resistance by these weak zonules. And lastly, after doing hydrodissection, when we decompress the nucleus and try to nudge it, invariably we find that the entire bag will be moving along with the nucleus. So in such eyes, saving the capsular bag itself is going to be a significant challenge. Now, to get the IOL trap technique right, we need to plan and execute few steps in a certain way. The first step is to ensure that we see well enough. Adequate pupillary dilatation, which is maintained until the end of the procedure, is the basic requirement. Using a pupillary expansion device is greatly beneficial. I prefer to use the B-hex ring, but occasionally I do use the hooks as well. Now, getting a well-centered and an exactly sized rhexis of about 5 to 5.5 mm is crucial. It's going to be difficult to achieve optic capture if the rhexis is bigger than this. On the contrary, a smaller rhexis may make the emulsification process and nucleus management a little bit more difficult. Getting a good hydrodissection is mandatory. I always keep an eye on the bag, monitoring its behavior when I nudge the nucleus, and I repeat the hydrodissection until I am certain that the nucleus cortex complex is totally devoid of any attachment with the capsular bag. Mind you, in such as the cortex is extremely sticky, I will be sticking onto the capsular bag. Many times I repeat hydrodissection and nucleus rotation after the CTR insertion, which makes it much more easier and safer. Number 4. Early insertion of CTR is critical, which goes a long way in supporting the loose zonules. And these loose zonules are likely to bear the brunt and get more damaged during nucleus manipulation and emulsification. Of course, one can use capsular hooks as well, but usually early introduction of CTR will serve the purpose very well. So my recommendation is not to delay the insertion of introducing the CTR. And one trick to ease the process of CTR insertion in the bag which already has this lens is by creating some space in the subcapsular region by aspirating cortex and then injecting sodium hyaluronate. This will help the process a lot. Nucleus division technique can be the surgeon's personal preference as long as the maneuvers are gentle and the emulsification process is being done in a very controlled fashion. A cortex aspiration is challenging in such eyes with weak zonules. In fact, the cortex will be sticking onto the capsule quite strongly and it doesn't come off very easily. So careful cortex aspiration using the tangential stripping technique along with viscodissection is very helpful. Being slow and patient gives us great dividends in such eyes. And lastly, coming on to achieving the IOL trap. Once the cortex is aspirated, a space is created under the iris and above the anticapsule by using the right OVD. A multi-piece hydrophobic IOL is implanted so that the distal haptic lands above the anticapsule. Then the lens is dialed in. Now both the haptics are in the sulcus. We go behind the lens and remove all the OVD which is there. Then with the irrigation handpiece in my left hand, the optic of the lens is gently tapped down so that it goes behind the rhexis. The successful optic capture is indicated by ovalization of the rhexis. So it can be confirmed later on by using the Sinskey hook to just lift up the anterior capsule. That's it, this is how it is done. Now these are some of the pictures which are taken post-op over a prolonged period of time. Well, I was surprised by the long-term stability and centration of these lenses. Of course, my longest follow-up has been 5 years, which is not long enough in such eyes with fluid exfoliation because it might still decenter or dislocate later on. But at least the initial results have been quite encouraging. Although the primary benefit has been that of better long-term stability, an indirect benefit which I have noticed is the decreased amount of pseudophacodonosis, which the patients do appreciate as they find it less annoying. Okay, now let's understand how the principle of IOL trap can potentially work. We have placed a CTR in the bag which provides equatorial stretch and 360 degrees support to the capsular bag. The haptics of this hydrophobic multi-piece lens are placed in the ciliary sulcus, but the optic is pushed back into the bag behind the rhexis. So basically, the optic and the haptic are in two slightly different planes. This potentially redistributes the weight as well as the forces acting around the bag. The anterior pull of the haptics can compensate for the posterior pull by the bag. However, there are two important factors which are critical for this technique to work. Number one would be sizing and centration of the rhexis. It's mandatory that we have an appropriately centered and sized rhexis. Number two would be a hydrophobic multi-piece lens. Now, this is a high definition picture which exemplifies the tackiness of a hydrophobic lens. We can clearly see the adhesion of the edge of the rhexis margin to the optic of the hydrophobic lens. Now, these are the fibrocellular proliferations which are moving across the anterior lens capsule and sticking on to the anterior surface of the lens, which ensure that the capsule is glued on to the anterior surface of the lens. And this tackiness of the hydrophobic lens is very critical for this technique to work. So that was it, and this was my brief overview of the IOL trap technique.
Thank you very much, Dr. Deepak Meghur, sir. Any questions? We can take it after Dr. Suhas sir's talk. Now I introduce our next speaker, Dr. Suhas Haldipurkar, sir. As you all know, he doesn't need any introduction, but he is one of the authority in the cataract surgery. We have learned from his techniques. In fact, we grew up learning with his techniques. And so today he'll be speaking to us on the retrofixated IOLs. There is a lot of controversy whether iris claw lens is good or bad. VIA surgeon says it is bad and anterior-segment surgeon says it is good. So there is a lot of debate versus with the retrofixated IOLs. And also he'll be speaking a little bit about the salvaging the bag. That is the CTR with the 3-piece IOL. So I think it's honor to hear from you, sir. Dr.
Thank you so
Suhas,
much.
sir.
Thank you so much, Dr. Srinivas, for this. I only wish this course was, in the prime time and not on the first day. But, all the same, let's talk. Thank you so much, all of you, for coming so early. Iris claw, I'm sure all the surgeons who do cataract surgery are well aware or are well versed with using iris claw lens. In fact, iris claw lens was introduced several years back by John Wurst, but there's been a modification in that, and today the modification is the transition from pre-pupillary to a more biologically appropriate retropupillary position, and the change in optic design from biconvex to concave. Now, the beauty of this lens is it's so quick and easy. Once you have the lens horizontally placed, you try and position it using your Sinskey. You always try and constrict the pupil. Try to get the lens behind. I prefer to do both enclavations from the same side pot. You take the lens behind, use a thinnest spatula that you have, and the lens gets fixed. So this enclavation, if done properly, you end up with a circular pupil. You do it either under dispersive viscoelastic or you take a suture and do it. But when you do that, you should also know how a disenclavation is done, because quite often, not in very large percentage, a patient may present with a hanging lens primarily because in the initial period it was not enclaved properly. So you should also know how do you manage this. First and foremost, you try and get this, if it's hanging on one enclavation, it is easy. Go with the specific forceps, hold the lens, go from the opposite side, very gradually progress, take your spatula through that claw and just try and reverse the procedure, and without much damage, the lens comes into the AC, and then you make a large opening under the visco, take it out. If the lens is defective, you may change it. If the claws are good enough, you can use the same lens. The second technique that I'm going to show is called retrofixated 3-piece lens. It is simply done where a 3-piece lens or a multi-piece lens is used to fix on the posterior surface of the iris. Here is a case that has presented with a long-standing anterior dislocated nucleus. There are different ways to manage this, but I preferred to do an anterior chamber phaco under viscoelastic. To do that, first I went with a cutter, removed any vitreous that was present, constricted the pupil. On a constricted pupil, the nucleus has lesser chance of dropping into the vitreous, and under the dispersive viscoelastic cover, a gradual and a safe phacoemulsification is completed. Then what I use here is a bucket handle technique. In the earlier days when the lenses were implanted, we had the holder and folder method, and the newer surgeons probably have not used it. This folder forceps is used to fold the lens where the haptics will come like bucket handle and go with the haptics pointing forward. Constricted pupil is there, so your haptics are pushed back into the pupil and the folder is released, the forceps is released, so the optic gets caught in front of the iris and the haptics have gone behind. After that, you can position your lens to the desired angle and a tenon suture is passed through the haptic on either side, and then it is sutured. Once the sutures are placed, you can push back the optics and you get a circular pupil. Whatever vitreous disturbance or the visco, you can always remove. Sometimes you get a circular pupil, sometimes you may get a peaked pupil, but with practice you can always get one. Now this is a case of spontaneous PC rupture, and this I have noticed with some of my patients with uneventful surgery done 12 to 15 years back would present with spontaneous PC rupture. And what I am demonstrating here is a single pass 4th row popularized by Dr. Amar for the fixation of these 3 multi-piece lenses. First, I would go with the spatula and get the lens in front of the iris. Now, this is a case where the PC has ruptured and partly the rhexis has ruptured. So there is not enough support for the lens to stay in the sulcus. But however, you push it back or rotate it back into the sulcus on the top of the capsule, constrict the pupil, go with the spatula through the side port and lift the optic up, and in a constricted pupil do a reverse capture. Then you position the lens in such a way that it is easy for you to take a suture. You have to, dent up or tent up the haptic to notice and then take a bite through the iris. The bite has to be in the mid-peripheral region. You can use the second instrument to, assist in taking that suture. And through a spatula, through a, your needle, blunt tip needle, you can get the suture out. And here use a use Lester's hook to create a loop, and through that loop, as described by Dr. Amar, the single pass 4th row suture is taken. Then I go with a cutter and do vitrectomy and remove the capsular remnants, and the optic is pushed back. The sutures are tied, and then you have a circular pupil, and this placement has no pseudophacodonesis. The lens is firmly sutured, and it is one of the quite a less invasive technique when you want to fix a lens in the absence of capsular support. Thank you. So I have
another 2-3 minutes.
Yeah, I just making up as a stopgap arrangement for
any questions from the audience. In the meantime, you can start loading, sir.
Yeah.
Any questions from the audience? I think you can please be ready, and as Dr. Suhas has to leave to another talk, so he'll answer your questions and then leave.
This is a different take on fixing the lens. This is a this is a single piece PMMA lens which has dislocated, and you have different ways of fixing. If the lens is good, you may use the same lens, and if you have to use the same lens and do a ab interno fixation, you can always get a suture and try and get the suture outside through the main opening, and try and dial the lens where the haptics come out of the wound, get the suture out, tight on it, and repeat the same thing on the other haptic. So this is one way where, without getting the lens out, the lens can be fixed. This is an interesting case where several years before, the bag was salvaged using a Sionis ring, and as expected, 8 years after, the tenon suture gives way and the lens dislocates anteriorly. The suture has torn. The one way to salvage this bag and lens bag complex is to use the same Sionis ring, this time with a nino suture, which is threaded through that central eyelet, and once it is fixed, since the original pupil had traumatic mydriasis, you try and create a pupil, so you have a bag lens complex that is salvaged, and the pupil is constricted, and the visual rehabilitation is improved. Another way of salvaging an extremely a deficient zonular structure is to use a sutured endocapsular ring. Before you place it, you have multiple iris hooks which are holding on to the bag. Once this endocapsular ring is placed and the bag is expanded 360 degrees, you have to fix the bag before the lens is placed in. And there are different ways of fixing the bag. And here I'm using an AIOC anchor. AIOC anchor is like a paper clip. It is in the single plane. What I'm taking is a Zimmermann technique of taking sutures, where you do not make a flap, but take zigzag sutures. And since the bag is poorly supported by the zonules, I place these anchors on either side, and once the anchors are put, the lens is pushed into the bag very gradually and placed. This is a very critical moment where, while putting the trailing haptic, one has to be careful enough to have it placed horizontally. And this is how a bag can be salvaged with some support and, fixing it with certain devices. Thank you so much.
Thank you, sir. Wonderful videos. I think we need to give him a good applause.
Thank you.
Sir, I think there should be a disclaimer that these surgeries should be tried only by the experienced and not by the beginners. You need to put that disclaimer. Sir, one question I had quickly. If you have any audience question, we would love to take it now. You showed the retrofixated IOLs with the suturing, and since we have iris claw, we all know that suturing under the iris is little more traumatic, and of course there can be a good centering. But what's the exact difference between the two, sir? Between the iris claw lenses and the three-piece taking it behind the iris and suturing it?
Yes. Contrary to the common belief that if you use it to suture the lens, it can cause iris pigment dispersion or cystoid macular edema. But the results have showed over the years that this lens, with absolutely minimal pseudophacodoresis, it stays well with very minimal incidence of cystoid macular edema or pigment dispersion. But my take on this is, if I have a lens in the eye that needs to be fixed, like in this particular, like typically my retrofixation is reserved for all those spontaneous PC ruptures, if and when I get, where I do not want, the lens is good, it had functioned well all these years, but today that lens needs to be out or it has to be fixed there and there. Instead of using the techniques like scleral fixated or Yamane's technique, I prefer retrofixation because I'm used to it. But otherwise, it is always iris clip, because iris clip has given fantastic results and it is so quick and easy to do.
Thank you, sir. Thank you very much. So if no questions, then we can, quickly, sir. Vishal, ready?
Good morning, sir. For the AIOC anchor, sir, you also mentioned that you are taking a suture through the endocapsular ring as well.
Yes.
So that also is tight, just one end or both ends?
The suture through endocapsular ring is till such time that the ring has gone in.
Okay.
Very often what happens, if you put the ring and the bag is too poorly supported and that there is no way to get the ring out, The moment the ring gets into the bag, I cut the suture and take it out. The suture never stays there.
Okay, thank you so much.
It's
And
only
sir,
a safety valve.
yeah, and the sutures for retrofixation of iris, they are the same 9O sutures?
The same Tenno straight needle,
Yeah,
Tenno on a straight needle called it's STC suture. That's the one I use.
thank you so much.
Yeah.
Thank you, sir. Thank you very much. It was really a wonderful presentation and treat to watch your videos. Thank you very much. So next we have our next speaker, Dr. Vishal Agarwal, who is an eminent vitreoretinal surgeon from Jaipur. So he'll be talking to us on the sutured, is old still gold? Over to Dr. Vishal, please.
Can I have the slides, please?
Over to Dr. Vishal.
Okay. Thank you, Srinivas, for having me here and making a part of this wonderful instruction course on secondary IOLs and IOL subluxation. So I'll be discussing sutured IOL and glued IOL, this old still gold. And for this presentation, I had to dig up many old videos which were very difficult to find. So just a brief, the best place for an IOL, as we all know, is the capsular bag, but intraoperative complications and subluxated lenses can lead to insufficient capsular and bag support. Historically, ACIOL and sutured SFIOL have been the mainstay of treatment. Of course, now we have many options like glued IOL and needle fixation techniques of Yamane and others. So I'll be, rushing through a few videos. So this is a very old video, a 20 gauge port vitrectomy system, and just a basic video of how to do a sutured SFIOL with excellent results. Although these are old techniques which we do not do much frequently nowadays, but they still have a place in many conditions. So you make two partial thickness scleral flaps with a crescent knife 180 degree apart. This is a case of a subluxated PMMA IOL. You can see the optic haptic of the IOL in the pupillary margin. You do so the important point is before making the entry into the anterior chamber, you do the vitrectomy, because if you make the scleral flaps after that, it will be hypotenuse and the flaps will be of not the required depth, and it will be difficult to make the partial thickness flaps. So once you have done the vitrectomy, made the scleral flaps, then you make a AC entry and that should also be biplanar so that it does not leak. I'll just forward this video, because then the IOL was on the retinal surface. You pick it up with the forceps and with the handshake technique, you take it out from the wound you have fashioned before entering the eye. So once it is out, now you take that, my preferred way of doing it is with the 4-point fixation with the 9O proline and with the straight needle, and you go through the scleral flap, take out the needle from the entry wound, and this is the eyelet based PMMA lens, and this is a very basic video to show the basics of sutured SFIL which we used to do and still do in many situations. So you take the suture through that eyelet on the haptic and bound it, and take another needle, make an entry around 1.5 mm from the limbus into the vitreous cavity, and just railroad the 9O proline into it and take it out from the second entry. You should be wary of the orientation of the IOL and the centration, because when you're going inside, it might tilt, and you might end up fixating it in the reverse fashion. The same thing, you just secure a knot, you don't tight it before titrating it. The same maneuver is repeated on the other side. You go with a double needle 9O proline, pass it through the eyelet. You can use a non-eyelet PMMA lens, you can use even a foldable lens, just wind it over the haptic, it works equally well. And once it's come out of the eyelet, after 2 or 3 loops, you go again inside the wound and come out with the help of a 27 gauge needle, railroading the needle into the haptic of the needle. So once they are out, then you gently nudge the IOL inside it and Again, just check the orientation of the IOL while inserting it and dial it gently, taking care that the sutures do not break. And once it is in the oblique position, then you tighten the knots at 0 and 180 degree and titrate the centration of the lens. So this is a basic technique of how to do a sutured SFIL. You can of course do a 2-point fixation also, in which you just pass it through a straight needle and take out the suture through the entry wound. But the centration and the tilt is much more better with a 4-point fixation. Coming to the glued IOL, this video I have included because this is one of my first videos around 10 years back which I did, and this is what not to do. This is for the youngsters and the juniors here. When you start doing these types of maneuvers, you have to be wary of these things. See the scleral flaps as compared to the previous case, and these are partial thickness flaps but irregular, ragged. The entry is premature, so I'm, dragging the iris root along with it, which can cause a bleed and make the media hazy. So this is again a dislocated IOL, 3-piece IOL, and I'm able to, grab it and bring it into the anterior vitreous cavity. The third mistake I'm doing here is I'm not bringing the IOL into the interior chamber, and this is dangling, which can be dangerous. The haptics are sharp and they can create breaks in the retina, and this should not be done. The ideal way of doing it should be that you bring the IOL into the interior chamber, stabilize it, and then do the maneuvers of exteriorizing of the haptics. So these are the few things which you have to remember while you're starting glued IOL. So this is how we do it. This technique was, pioneered by Dr. Amagarawal sir. And this is a patient of retinal detachment with a subluxated IOL, with a 3-piece IOL which has been subluxated. And you can see. So we thought we'll not, take out and explant the IOL and refixate it with the glued IOL technique. So you again make, you mark the 0-180 degree with a marker so that there is no decentration. You make partial thickness scleral flaps. Then you make a good depth 26 gauge chariot tunnel, the scleral tunnel. And just to, mark it, you can stain the tunnel with the dye so that you don't forget we have made it. You make entry with a 23 gauge trocar system. Just expose the haptic. And it's very important to bring it into the interior chamber to visualize it, to stabilize it. Once it is there, you insert the glued IOL forceps and catch hold of the tip of the haptic and exteriorize it and tuck it into the scleral tunnel you have made. And you can use a fibrin glue, you can suture the scleral flap, that is your wish. Now you just imagine, you can just see the stability of the IOL. The whole process of the main surgery was done after this. This was a retinal detachment with the anterior PVR. Everything is being done under centration, and this is the final view under air. And you can see there is no air in the AC. The IOL is well centered. So this is the beauty of this technique. I'll not discuss Yamane because it will be discussed by Dr. Aditya in the next talk. And this is one more video of, IOL acrobatics as we call them. This was a blunt trauma with a 4 haptic acryos lens, and it was subluxated. Again, we thought we'll not explant the lens. So we just went, we marked 0-180 degree, made a scleral flap. We could have done a Hoffman pocket also here and put a cannula at one side and a 26 gauge through the haptic and the back complex, and railroaded a 90 Prolene from that side. Took out the sutures, did not tighten it, did the same maneuver from the other side, took a cannula, made a MVR entry and put a cannula there just so that the suture is not entangled in the iris, and exteriorized the sutures from the other side. And when all the 4 sutures were outside, we tightened it and we had a good and a well-centered IOL at the end of the procedure.
Thank you. Thank you.
So just to conclude, sutureless IOL fixation techniques are the future of secondary IOLs, but still sutured SFIOL comes in handy in many situations. Of course, the advantages of sutureless IOL fixation techniques are reduced morbidity and decreased operative time. But a definite learning curve is present, and younger surgeons should have a backup plan for the initial cases. Sutured SFIOL are time-tested techniques with validated data on long-term safety and have a reduced chance of tilt and decentration. I think the learning curve is much less than the haptic fixation techniques, and they have a definite place in select cases like a compromised anterior segment and a poor iris support.
Thank you, Dr. Vishal.
Thank you so much.
So we can take the questions at the end, and now we have another eminent speaker, Dr. Aditya Kelkar sir. He has won numerous ASRS videos as well for his beautiful video presentations. Please request him to speak on the sutureless SF IOLs, and is new really the platinum. I thank Dr. Vishal for the wonderful presentation.
So at the outset, thank you, Dr. Srinivas, for the kind introduction and also for inviting me to speak in your instruction course. So I'll be talking about sutureless scleral fixated IOL, and I'm sure all of us who do phacoemulsification, a situation where we have a posterior capsular tear and inadequate bag support is not new to us. Thankfully, this complication happens in about 1 to 3% in the experienced hands, and not all patients require a secondary IOL or a scleral fixated IOL. However, when we land up in a situation like this, we have various options like anterior chamber IOL, iris claw IOL, scleral fixated IOLs. The reason why scleral fixated IOLs is preferred by many of the experienced surgeons is, although the learning curve may be a little more, but it's more physiological because it lies in the sulcus, less risk of glaucoma, inflammation, endothelial damage, and pupillary dilatation is not affected. Although technically challenging, as I said, it may require a second sitting in some patients where you don't have a planned SFIOL option ready on table when the situation demands. At the same time, with the sutured SFIOLs, it's known to have a late dislocation. So the SFIOLs can be broadly classified into sutured, sutureless, and glued IOLs, and I'll be talking about how we do the Yamane's SFIOL. So popularized by Dr. Yamane in 2016, we use a 27 gauge needle because the 30 gauge thin wad needle, as described by Dr. Yamane, is not available in India. And I use a 3-piece IOL like a Sensor or a Technis IOL. That's one of the preferred lenses that I use. So first, engaging this haptic, always note that don't hold the haptic close to the tip. Hold it a little away so that engaging it into the needle becomes easy. And I usually find that the trailing haptic is more difficult, so I prefer using a 26 gauge needle here as compared to the 27 gauge which I use for the first haptic. Always keep the infusion cannula ready and on as and when required so that the chamber is always formed. Again, note that I am not holding the haptic very close to the tip. Then if you hold it too close to the tip, then the maneuverability into the lumen of the needle becomes a little tricky. So hold it a little away. You can either use a McPherson's forceps from the main port, or you can make a side port and use a intravitreal forceps to dock this haptic into the lumen of the needle. And although Dr. Yamane recommends simultaneous explantation of the haptics, I do it one by one so that I am sure that at least one haptic is well secured. And then once first haptic is brought out, I hold it, my assistant holds it with the help of a McPherson's forceps, and then I move on to externalizing the second haptic. So that I am very sure that I don't end up with a situation where I slip the haptics and the haptics are lost, and then you may be feeling really sorry for all the effort that you have already taken to get this haptic out. So after that, a flange is made and the haptic is secured. So this is what typically happens, but in special situations you must be ready that when you are dealing with Yamane's SFIOLs, once in a while the haptic can play a trick on you. And while I was doing this scleral fixation using this 27 gauge needle, the haptic engagement went on quite smoothly. As you can see, it was not as difficult. And usually this trailing haptic, which is the most difficult job in Yamane's SFIOL, the mistake probably I did was I was very over enthusiastic in getting the haptic too much into the needle of the trailing haptic. So I ended up losing the haptic on the first side. Luckily I could grasp the other end and pull it out and flange. So now I have one haptic inside, so going back with the needle was getting difficult because there was already some chemosis and subconjunctival hemorrhage. So I introduced a 25 gauge trocar here, and with the help of forceps I got hold of that dislocated or a dislodged haptic and then brought it out through this trocar cannula. and then the rest of the procedure remains the same. Also, you should be aware of another complication which you may encounter is usually these things happen for the trailing haptics. So the first haptic usually is no problem, but when the trailing haptic is being introduced into the needle, because the angle is quite odd, although the things were going very smooth, I ended up with a situation such as this where the haptic got broken. So be aware of these situations, and I'm sure we have tried to compare various scleral fixated IOLs. We've not found much of a difference, including iris claw versus SF IOL. Of course, the ovalization of the pupil is an issue with iris claw IOLs. So thank you once again, and thank you Dr. Srinivas, and thank you audience for your patience. Thank you.
Thank you very much, Aditya sir, for those beautiful videos, very good clarity and beautiful technique you emulated. So last, I'll show 4 videos. So about the dangling IOLs, what to do in case if the IOL is already one haptic is dangling. So let me go ahead with these last 3 videos. So this was traumatic sided, and the patient had the ERM and the VMT also. So as you can see, one haptic had fallen down, but I went and checked inside. The other haptic was quite stable, so I didn't want it to disturb that haptic. And this was secondary to the trauma. So initially what we did was to do an ERM and the ILM peeling. And as you can see, it was already quite adherent at the foveal edges, so I didn't want it to pluck it off. So the better I did was to trim it off with the help of the cutter. And once this procedure is completed, now I went ahead and fixed that single dangling haptic. So how to do that? So I used the modified technique of Sergio Canabrava technique. Using a 6-O-proline is introduced into the vitreous cavity using a 30 gauge needle. And I'm just trying to thread it inside in the vitreous cavity. The suture is passed through the eyelet of the SF IOL in the vitreous cavity, and we should always remember that the passing has to be upside down, not the downside up. Otherwise, if it is downside up, the bulb what we create might irritate the ciliary body, and it might cause a mild uveitis kind of reaction. So here, after externalizing it, I just try to flange the end of that suture cauterized from the flat bleb, and internally it is very important to check it. Otherwise, if it slips inside, then the whole procedure has to be repeated. So the other end is brought out, it is cauterized, and you can do a good centration. You can just push it in the scleral tuck, and it's a well-centered IOL at the end. And this is post-op day 1, and this is post-op 1 month. So the patient is doing well. Now coming to the next video is another thing. I'll be just showing it courtesy Dr. Guruprasad sir. So here you can, he just did a vitrectomy in this case. So here they tried to do like how I showed using a 6-O-proline. So this is another technique. If you don't have 6-O-proline, you can use the same 10-O-proline itself. So here a railroading technique as showed by Dr. Vishal. At the end of that 10-O is taken, and now it is passed on through the eyelet in the vitreous cavity. Of course, it's a bimanual procedure. The chandelier is being used, and another entry is made to bring it out, that 10-O-proline. So you can see it just brought out the 10-O-proline outside, and under the flap you can always tie it up. So now you can achieve a good centration here, and the procedure gets over within few minutes. So this is the another video I wanted to show, is in case you have a sutured SF IOL and one haptic is again dangling. So here what we can do is first check whether that suture continuity is there or no. See here, so what happened, the suture knot had got loosened. So what we did was just to pull it and see. If the IOL is pulling it up, that means there is a continuity. So taking a stay suture to make sure that it is placed, and then you cut the previous knot. So once you cut that previous knot, then and then just tie the knot. So this procedure gets over within 10 minutes. So this is how we can refixate it. So I think I request the next session speakers and the moderators to please come up. Thank you very much. Hope, and I'm really surprised to see so much of crowd at the 8 o'clock in the morning in Kochi. Thank you very much for coming all the way in the morning. Thank you.